Hi, in this video we're going to talk about the research support for the toolkit and for the concussion management protocol. So it's this research, there's more, but this research was used in order to decide what was put in the toolkits, and then really when we saw all the gaps in the literature is when we decided that we needed to put together the concussion management protocol that helps to fill in all of those gaps. So we're going to go quickly through some of this. So this is the latest data from the CDC about concussions, traumatic brain injury related visits in the ED, 2.53 million. Now that underestimates the overall number because most will go to their primary care provider. The next box shows me that a lot of people are treated and released, and then the final box, the deaths, actually shows me that a lot of people are surviving. If we look at the 288,000 hospitalizations versus the 57,000 deaths, we see that a lot of people are surviving with what can be a very substantial burden. So that's what we're hoping to try to help with here. This is Tennessee data, and what we like to show this one for is to show that the sports-related injuries are really only about 10%. So we have made great strides in educating people about, and this is across the country, not brain links, but educating people about sports-related concussion, and that is awesome. But we need people to understand that there's a whole lot of other ones out there as well, and that's what this data shows. So most people, like I said, are going to be seen by their primary care provider, 82%, and that was a very large study. I'm going to be showing you information on children and adults, and often it makes intuitive sense that a point that you're seeing related to one of the populations relates to the other. We can't say that for sure until we see the research, but intuitively it makes sense on some of these issues. For 0 to 5, there is no validated age-appropriate symptom scale. The CDC tells us to use one. There isn't one for this population. They're aware of that. We're hoping that there will be one soon, but there's not. And we are missing these little guys. We are missing them a lot, and we need to be careful because their symptoms look different. So Suskauer and colleagues shows us that their symptoms are going to be the same. A concussion is a concussion. It tends to produce the same types of symptoms, but the younger guys can't tell us that. They can't tell us that their stomach bothers them necessarily, or I have vertigo. They can't use those words, but we can look for things like appetite changes, behavioral dysregulation, decreased engagement, disrupted sleep, continence issues, and now this group has continence issues anyway, but we're looking for something that they had mastered, like maybe sleeping through the night, and now they are having issues. Increased dependence, kind of a clinginess, and stomach aches. And just a word on the behavior issue. So initially, it looks like decreased engagement. They're pulled back, they're quiet, and then over time, as they begin to heal, we see a behavioral dysregulation. And sometimes at that point, it's so far past the concussion, even if it's a matter of weeks, that people don't relate it back to the concussion. So we need to watch for that pattern in the little ones. So here are just common symptoms in concussion. That's for anyone, any age. And again, we're looking at it a little bit differently for the littler ones. They tend to have more health problems, so more kids with a traumatic brain injury are more likely to have learning disabilities, and ADD, ADHD, speech and language problems, developmental delays, anxiety, bone, joint, or muscle problems. I want to talk to two of those. ADD, what we see in the field is that kids with concussion, TBI, are often referred back to their doctor with a complaint of ADD. They're treated for the ADD, which it is fine. That's a good thing, but it might be missing other symptoms that are there as well, other problems. So when there is a child that's being referred to ADD for ADD management, we probably need to be looking deeper to see if there was a concussion, just to rule that out, and be looking for any other problems, memory, organization, anything else. And the bone, joint, or muscle problems, I want to speak to that a second. This is probably typically because of the mechanism of injury. So the spinal alignment is thrown off, and sometimes it looks like this child comes into the school nurse's office and they have a pain in their hip, and then they have a pain in their shoulder, and then a pain in their neck, and it kind of looks like this child might want to just get out of class. And again, we have to, if there's a history of something like a car accident or falling down the stairs or something like that, we have to consider that it could be a misalignment issue, and we need to make an appropriate referral. So one of the gaps in the literature is there needs to be ongoing monitoring, referring any age. The children with all levels of injury, mild, moderate, or severe, are more at risk for persistent behavior problems, and the risk rises with the severity of the injury and the younger age at injury. So we have to be watching them over time. Even in children with skull or brain tissue damage on imaging, so this is a significant injury. If that's showing on imaging, it's a significant injury, and only 1/4 of those received rehabilitation services, only 1/4 received neuropsychological assessment. And this study concluded that healthcare providers should provide information to parents on what to look for over time, and what are the long-term implications. And we would certainly support that, being a downstream organization that often finds folks floundering, not knowing what to do. Healthcare providers should make appropriate referrals at the time of diagnosis. Now, our concussion protocol says by 4 weeks. At the 4-week mark, we need to have made them. What this is referring to more is those the significant injuries where they should be immediately referred to rehab if they're in the hospital system. And so we need to be making those referrals early. And referral to rehabilitation can help with the transition to preschool. From experience, I can tell you also that it will help with transition to any level of schooling and back to work. So we don't have enough monitoring. Even if a child is cleared, or an adult, if a child is cleared from Tennessee early intervention or any early intervention system, that may not mean that they don't need support. What we're finding across the country, this comes from folks at the CDC, is that sometimes they are passing that initial screening, the developmental screening, but they would potentially fail a later one because we don't always see issues until later. So they haven't changed enough initially for us to see that at that early. This TEIS is going to be under 3 years old. If they've been admitted to a hospital, we see that people often who have spent maybe 3, 4, 5 days in the hospital and treated, and still have ongoing issues, and without a lot of referrals. So we need those referrals in place. If they were just treated and released at an ED or a primary care provider's office, they still might have ongoing issues. Just because they were told, okay, you're good, they may still have downstream issues. We know from the literature that medical issues at the time of injury, unstable intracranial pressure, blood pressure, or oxygenation, delayed nutrition, or seizures, they're more likely to have a decreased IQ at 12 months. So even in mild traumatic brain injuries, studies show that there's a 17 to 33% incidence of cognitive deficits 1 year later. So again, looking downstream. And all ages are likely to have another injury, to become obese, to become incarcerated, to have substance abuse issues, including opioids, become depressed, become socially isolated, and more. This group is particularly prone, and this is all ages, to lots of downstream issues. A substantial portion are not going to go back to their primary care provider during that first year following injury, and many will have unmet or unrecognized needs. And this, because of information like this, is why we put in give information, educational information on that very first day that you see them, if you're a primary care provider, because you may not see them again. It also is information like this, the impetus for bringing people back at 4 weeks to make sure that we are taking a look at them. And the reason for unmet needs, one of them was physicians' lack of a referral or a recommendation. Could be because they didn't come back in 4 weeks. They didn't come back when they were having follow-up issues. And services are not provided in the school settings, and they're not always. School only needs to provide what is needed for education. So it can be very appropriate to have a referral to an outside program and to also receive services in school. And then, of course, cost is always a factor. And where there was family dysfunction or poor coping, the child had greater dysfunction. So we need to be helping our families. They needed more information, more emotional support, and access to community-based services. We know that if, as part of their medical care, we provide systematic transition services, then they're more likely to receive the supports that they need at school. School doesn't have to follow non-medical recommendations, like an academic recommendation. The school is perceived as the expert at that, so they don't have to follow that. They do have to follow medical ones. But if you do make recommendations for accommodations, which is academic, they are much more likely to follow that. If we use the ACE screening tools, which you will learn more about in the in-office tools, the screening tool, and then the care plan is in the send home information, then we see increased patient follow-up and improved recall of and adherence to the emergency room discharge recommendations. Makes sense. We give them something, then it's much more likely. This was a big study on 11 level 1 trauma centers across the country. They saw that less than half received educational material at discharge or saw a healthcare practitioner within 3 months after injury. Only 27% were called by 2 weeks. Follow-up care varied by site from 19% to 72%, big difference. For those with a positive CT scan, over 1/3 had not seen a medical practitioner for follow-up. Even among those with 3 or more moderate to severe post-concussive symptoms, now that's a substantial burden at that point, 3 or more moderate to severe post-concussive symptoms, only about half saw a medical practitioner within 3 months. So we need to be supporting these people earlier on and giving them information that they need. And of those that did see someone, 80% said that it was helpful. The majority saw a general practitioner, 38% saw a neurologist. Only 15% reported visiting a clinic specializing in TBI care. And these are the programs that see these symptoms all the time. So they're a great referral place. And then finally, the same study saw that not following up can have negative consequences, that even if we know already that providing educational materials alone to those with MTBI, mild traumatic brain injury, improves outcomes. So we've got to be, that's what recommended, give them information at that very first diagnosis visit. They believe the findings show that there's a lack of understanding among practitioners of the substantial symptoms and life burdens experienced by many of those with mild injuries. So hopefully that gives you a little more information about where the toolkits and the concussion protocol came from, and hopefully that helps you also with your own practice. Thanks.